Yes, sir, we are live now.
Good evening to all the respected faculty. Myself, Dr. Sachin Chaudhary from Medical Affairs Team Zydus, would like to welcome you all for today's launch of Avanext. Now, when it comes to human health, the Zydus has a long history of providing the best. Even we talk about the male sexual health disorders like erectile dysfunction, the Zydus has a long legacy of providing the products which will make their life better and better. So to continue our legacy, we are again ready to serve a new launch of a new molecule in this particular basket of male sexual health, that is Avanafil with the brand name Avanext. And we are very happy to say that we are the first one who is going to launch this molecule in the Indian market. And we are launching this molecule with the help of SASAM, which is a very reputed organization in our India, that is the South Asian Society of Sexual Medicine. So we have small AV for you guys. So can we please play the AV?
Times have changed, bringing with it numerous changes in almost every aspect of life. Lifestyle has changed. Due to advanced information technology, communications, digitalization, today time is critical for virtually everything. Time is the essence. Today, fast world has also created various unwanted conditions like stress, work issues, anxiety, giving couples very little time for themselves. The result: increasing cases of erectile dysfunction. The result: less time for building relationships. The result: unhappiness. Zydus Forteza, a division of Zydus Healthcare Limited, launching for the first time in India. The fastest acting phosphodiesterase type 5 inhibitor. Presenting Avanext, Evanafil 100 mg and Evanafil 200 mg. Happiness is mutual. Why wait? It's fast. Onset of action in just 15 minutes. Best among all available PDE5 inhibitor. It's effective. Improvement in SEP2, SEP3 and IIEF scores. It's safe. High tolerability and safety profile for diabetes or cardiovascular patients. It has no intake restrictions. Eat and drink what you like. Can be taken anytime. It has least adverse effect. Less incidences of headache, blurred vision and nausea. Let them experience happiness that is mutual. Let's make every patient of ED happy. For the first time in India, presenting the fastest acting PDE5 inhibitor, Avanext, Evanafil 100 mg, Evanafil 200 mg. Happiness is mutual. Why wait?
Thank you for that. So to talk more on Avanafil, now it's time to introduce uh, Dr. Deepak Jumani. Dr. Jumani is a name which requires a no introduction, but still I want to call out his achievements in the field of sexual health. So he is an American board certified clinical sexologist. He is the first sexologist from India to have conferred FRCP from Royal College of Physicians and Surgeons from Glasgow. He is the only Indian to be appointed in the Scientific Committee of International Society of Sexual Medicine. Also, he has also been awarded an Dronacharya Award for his excellent awareness regarding the sexual health. He's been also been the course director and mentor of fellowship in clinical sexology, which is conducted by MUHS. He's also been the co-chairman of Indian Medical Association initiatives for sexual health. And the list is ever ending. So currently, he's been associated with Sir JJ's group of hospitals and Grand Medical College, and also he runs his own clinic in Mumbai. So please allow me to welcome Dr. Deepak Jumani, a senior sexual health physician and counselor. Over to you, sir.
Thank you, Zydus. India is a land of Kama Sutra. Khajuraho, and Lord Krishna. Sage Manu, who wrote Manusmriti, Chanakya, who wrote Arthashastra, and Rishi Vatsayana, who wrote Kama Sutra. All these Vedas are our richest asset of our culture and religion, and all were written for a purpose. This means that all these ancient civilizations had enough wisdom and experience, and hence they expressed with so much ease their emotions and feelings. These scriptures or sculptures on the temples of Konark, Khajuraho, etc., tell us how their lives are vibrant. And this is the narrative which we have lost today. We all are aware of the fact that erectile dysfunction is one of the commonest male sexual dysfunctions which we see in our day-to-day practice. Every male has some or the other woes. And what happens is, whenever he has certain issues like this, it's an attack on his manhood. He has an avoidant behavior. He deprives his partners of the sexual rights which he has. And also we know that erectile dysfunction is the earliest marker of cardiovascular disease, which is the commonest cause of mortality in our country. So it's important for us to identify and elicit the history of erectile dysfunctions. The onus lies with we physicians. And today, we have a much better treatments available for this particular sexual dysfunctions. We have, of course, counseling forms the benchmark and the mainstay of treatment, along with lifestyle modification, control of all the metabolic disorders, and of course, pharmacotherapy. We are very fortunate to have Zydus Fortisa division, who's given us the basket of all the all male sexual dysfunction drugs which we have, like sildenafil, tadalafil, sildenafil, and now a new molecule, which is Avanafil. How important it is for us to have this molecule, besides the fact that we know that there are 40% of pharmacotherapy patients who take PDE5 inhibitors are resistant to it or are non-responders. Is it more effective than the other PDE5 inhibitors? Is it very safe from the adverse side point of view? Is the sexual encounter profiles better? To know all about this, this is the launch which we have had from Zydus. And it's going to be this drug is going to be a boon and a game changer for all sexologists, urologists, psychiatrists who's been treating erectile dysfunction. To know more about all these things, let me invite my mentor, Dr. Rupin Shah, who's a classified endosurgeon and a microsurgeon attached to Lilavati Hospital. He has trained thousands of urologists across the country and globe. He's also a BC Roy Award winner. And the finesse, the precision, and the surgery with which he operates is a feast to all of us. I also invite Dr. Narayan Reddy, who has also been my mentor. He's a president of Asia Oceanic Society for Sexual Medicine. He's also emeritus conferred by Council of Sex Education and Parenthood International. He is Bhishma Pitama of we all sexologists here. Friends, put your hands together and welcome Dr. Rupin Shah and Dr. Narayan Reddy. Sir, the air is all yours. Please take over.
Dr. Rupin, you are muted.
Audio issues. Muted, sir. Need to unmute.
So I said, Deepak, thank you very much for the introduction, and more so for pointing out the importance of sexual health in a healthy relationship. Today we have one more drug being introduced in our armamentarium, and we have a galaxy of speakers who will give us a very interesting perspective on this. The first speaker today is Dr. Vineet Malhotra. Vineet is a very well-trained urologist who has focused a lot of his time and attention in the field of andrology. He has done, of course, a lot of work in sexual dysfunction, is one of the leaders in penile prosthesis surgery, and is one of the few andrologists who is also very well trained in male reproductive microsurgery, treating obstructive azoospermia, doing sperm retrievals. So Vineet brings a wonderful perspective to the field of andrology, and I'm very happy to invite him to introduce Avanafil to this audience. Over to you, Vineet.
Thank you so much, sir. It's always a pleasure when your teacher introduces you to the audience. So very quickly, I'll start with this. We have a 15-minute time frame to discuss the indications, dosing, interactions, and adverse events and the global experience that we have with Avanafil. So we all know what the definition of erectile dysfunction is, but this is something that we need to reinforce in our patients, and this is why this always finds a place on these slides. And it's important to understand that satisfactory sexual intercourse, the penetrative intercourse, which allows persistent maintenance of attaining erection to the completion of sexual activity, that's very, very important. A lot of couples do not realize the full significance of what normal erectile function and dysfunction is. And there's a wide overall prevalence. In fact, as we know, the Massachusetts male aging study, almost 50% of men in the age group above 40 to 70 have a some sort of erectile dysfunction, and this increases exponentially with age. Now with the metabolic factors also increasing in our country, we understand that diabetes, cardiovascular risk factors, obesity have further added to the problem of erectile dysfunction in our country. And so when we talk particularly about Avanafil, do we have different indications for using Avanafil? Actually not. All men with ED where APD5 usage is not contraindicated is an indication where you can use Avanafil. It is also an on-demand medication. So we've used PD5 inhibitors in two forms now, which means we're using them on demand or we are using them as daily dosage medication. Avanafil is in the group of second generation PD5 inhibitors that falls into the on-demand use of medication. And it can be used where there is no hypersensitivity to any of its components. And particularly I would like to say that when you have unplanned sexual activity, now where is it that timing would become very important? It is where you are likely to have unplanned sexual activity and you have a short window, 15-20 minutes, where you think the sexual activity may or may not happen, and there the longer window of a 45-minute to an hour of other PD5 inhibitors may not be suitable. And that's particularly where I think this finds very, very useful indication. Again, I'm not going to go very much into the details of what and how the PD5 inhibitors work. We'll talk a little bit about the history because I'm not sure everyone would be well versed with this. But PD5 type 5 was first discovered by Francis and Corbin in 1980. And very interestingly, we all know about this molecule UK92480, which later on came to be known as the Viagra or the sildenafil citrate, was synthesized in Pfizer labs actually to treat angina. And what they'd actually found initially was that it lowered vascular resistance and platelet aggregation through a sodium nitroprusside channel effect. And the side effect that they noticed, which actually brought a lot of excitement to them, was the significant side effect of inducing erections. And eventually in 1998, there was US FDA approval to use sildenafil citrate for men with erectile dysfunction. So from the late 80s, so 89, 90 to about 98 when it came into general usage. And we have divided them broadly into first generation and second generation PD5 inhibitors, and Avanafil will form a part of the second generation. Pramod, I'm sure, is going to cover the comparisons between various PD5 inhibitors, and I restrict myself to Avanafil only. Again, we know where all PD5 inhibitors work, and that's to make sure that there's more cyclic GMP circulating, which means that you prevent the breakdown of cyclic GMP to 5-cyclic GMP, which leads to detumescence. And that is the action of competitive inhibitors, PD5 inhibitors, such as all the previous PD5 inhibitors and Avanafil. So it is this cycle of sexual arousal resulting in the release of nitric oxide, allowing the conversion of GTP to cyclic GMP, and then eventually accumulation of this, allowing a persistence of tumescence or erection. Avanafil is available as 100 milligram and 200 milligram tablets. And this was actually developed in Japan, but very early in its phase, it was bought by an American company, and And the phase 3 trials were actually completed in the US. And finally, the FDA approval for use of Avanephil was got in April 2012. It's taken a while, So if you look at drugs which have made it into India and those that haven't, this has been one which we've actually waited for some time, including another drug which has still not found its way into India, which is vardenafil. So we've actually had only two significant PD5 inhibitors that have been widely used in the country, and others have not been so popular. This is a very complex chemical structure, so if anyone wants to remember that, you can go through this slide. But essentially, this is minimally soluble in water, and this is what I wanted to point out, because there's a lot of interest now in soluble or oral disintegrating PD5 inhibitors. And unfortunately, Avanavil will not come into the group of oral disintegrating forms, because it's not as soluble. And the ones that are being worked on more often are sildenafil and vardenafil. Uh, the dosage recommendation, so we've spoken about the indication. The dosage recommendation is 100 milligrams, 15 to 30 minutes before sexual activity. And you may titrate the dose. The availability is 102 milligrams, but you can actually titrate from 50 milligrams, as we use 25 milligrams or even 12.5 milligrams of sildenafil occasionally. You may titrate the dose based on response and adverse events noticed. Now, it is rapidly absorbed, which means you see the maximal plasma concentrations as early as 30 minutes and peaking at about 45 minutes. So 30 to 45 minutes where they reach their Tmax, it's 99% bound to plasma proteins. Again, it's cleared primarily by the cytochrome P3A4 system and also the hepatic microsomal enzymes, and extensively metabolized after oral administration, majorly excreted through feces and also through the urine, about 20% through the urine. Uh, I'm not going to focus on the comparison because I think Pramod is going to do more of that. But what I need you to focus here is on the Avanafil pharmacokinetics, which means you're looking at a Tmax, which we've discussed is between 30 to 45 minutes. Onset of action as early as 15 minutes. So you can see their tagline, which is action within 15 minutes. And that's a very early time. You actually can do without planning for sex if you have onset of action as early as 15 minutes. There is some delay with high fat meals. So, I this is like sildenafil. If you look at sildenafil, you don't every time have an interaction with that, and it's known to delay the onset of action. But if you look at the comparison, Cmax for avanafil and vardenafil is delayed when you've taken a high fatty meal. So if you recommend not to take it along with a high fatty meal, though you can take it with the meal, it doesn't make too much of a difference. It has a very short half-life of a terminal half-life of 3 to 5 hours, which actually, so in some studies, they actually did 2 doses in a day. So you can actually even have safe usage of 2 doses in a day without actually having adverse events. We've already noted the mechanism of excretion. The other thing with this is the adverse event profile. And if you realize, Avanafil is far more selective than the other agents, especially when it's a head-on comparison with sildenafil. The adverse event profile is much, much less. And so when you're looking at two and on-demand agents in the country, which are going to be very similar in their action, I think Avanafil is going to form a competition for wherever sildenafil is being used. If you're seeing rapid onset of action, if you're seeing a much better tolerability, you're going to have an agent which is going to become popular. So far more selectivity in terms of PD5 versus PD1, PD5 versus PD6, and PD5 versus PD11. So you're finding this to be a significant advantage over sildenafil. Again, you don't require to adjust doses compared to age. You have minor modifications if you're looking at moderate renal failure or hepatic failure. And importantly, as with any other PD5 inhibitor, it should not be used concomitantly with use of nitrates. This is a absolute contraindication, and as is any hypersensitivity to any component of the tablet. So we know interactions with nitrates known to happen. Alpha blockers, we actually titrate them. So because it has a very short half-life, you can very easily have the alpha blocker dose in the morning and a Vanafil in the evening, and there's no problem with that. Again, we've not noticed so much of an impact of alcohol intake, and you can titrate that also with the intake of PD5 inhibitor. When you look at adverse effects, they are similar to what you would find with sildenafil, which means you have headache, flushing, you have some GI symptoms, nasal congestion. These are the major symptoms that have been noticed, and most of them, because of the short of life, actually go away fairly quickly. So it's a very easy medication to use. They actually did single dose usage of up to 800 milligrams in patients and found even that to be okay, though the adverse event severity was for a long in a higher percentage of people. So overdosages also up to as much as 800 were not associated with fatal events. Now, if you look at some of these studies which were done, both placebo controlled and those that were comparative studies, it's found that, so most of these were done with either 50 milligram or groups of 100 and 200 milligrams. They found these two groups because the adverse event profile of those that used 50 milligrams was very, very good. The adverse event profile of those that used 100 and 200 milligrams was very similar. So and the efficacy of the 100 and 200 milligrams was very good, whereas the efficacy in the 50 milligram group was lower. The dose was usually taken 30 minutes prior to initiation of sexual activity, and as discussed in the presentation initially, the SEP2 success rate was higher during the treatment period or end of treatment with Avanafil 100 or the 100/200 cohorts. Similarly, SEP3 success rates were also far better compared to the baseline levels with Avanafil 100 or 100/200 groups. And the IIEF domain score improvement in the cohort groups was significant with the Avanafil 100/200 groups compared to Braille, the baselines. So the long-term tolerability improvement in sexual function, especially along with the rapid onset, makes it well suited for on-demand treatment of erectile dysfunction. Another study by Goldstein et al., which was a 12-week multi-center double-blind placebo-controlled trial, including 390 men. This was diabetes with erectile dysfunction, and again receiving 100 or 200 milligrams of Avanafil versus placebo 30 minutes before initiation of sexual activity. And here they permitted up to 2 doses in a 24-hour period where they were separated by 12 hours. So, this is something which has been shown that, even using up to 2 doses in these men is safe, and you can actually go ahead and use that. Though I don't think that will come out as a broad recommendation, but that's something that can be used. This is a placebo controlled trial, and here in the group of those that used Avanafil 100 versus placebo and Avanafil 100 versus placebo, you found the intercourse rates, the vaginal penetration rates, and the IIEF compared to baseline rates to be significantly improved in men that received 100 or 200 milligrams of Avanafil. So across the board, the usage of Avanafil 100 and 200 milligrams, as with all other PD5 inhibitors. So there was actually a study where this was compared as whether it was inferior to sildenafil in terms of its effect on erectile dysfunction, and that was also not found. It was found to be non-inferior to sildenafil. So potential efficacy is similar to all the other PD5 inhibitors that we are talking about. So as we talk about this, current evidence suggests that successful vaginal penetration, successful intercourse, IIEF domains, they all improved significantly. Tolerable side effects, adverse effects. 100 milligrams or 200 milligrams, though the full dose 200 milligrams would have a higher efficacy. And there have been recent meta-analyses. In fact, Wang et al. Had one which is 2019-2020, which will probably figure in the end. So prospective RCT, double-blind, two-armed, active controlled, multi-center, non-inferior phase clinical trial. This is the one that I was talking about, showed that Avanafil is non-inferior to sildenafil in improving the IAF domain scores at the end of 12 weeks of treatment. Also found to be non-inferior, superior to sildenafil in other efficacy parameters, including percentage of attempts with successful vaginal penetration and successful intercourse. improvement in eye scores in other domains. So it was found to be effective, superior to sildenafil in percentage of doses having erection in less than 15 minutes. Now, this is the significant difference that was found as an advantage of Avanext over sildenafil, and both the drugs were well tolerated. So the tolerability profile was found to be similar, though there is data which shows that it is more selective for the PD5 and hence has better tolerability. So this is the study by Wang et al., which shows that PD5 inhibitors currently prescribed for treatment of ED generally have a favorable safety profile. However, an increased risk for visual disturbances and hemodynamic disturbances and musculoskeletal. All of these three we've seen, PD1, PD6, PD11, higher specificity for Avanext compared to sildenafil. So because of this higher selectivity against all other PD isoenzymes, it is known to be having a lower incidence of adverse effects. So currently, what would we take home? We are starting, or we are going to be embarking on introducing a new drug into the market. This has been around for a reasonable amount of time worldwide, and we have a lot of data that we can take information from. It has a safety benefit. It has higher specificity to PD5 isoenzymes. It's not shown to have significant adverse impacts to BP and heart rate. It's known to have quicker onset of action and almost a similar duration of action. So overall, if we look at it, you're looking at quicker onset of action, you're looking at a short half-life, you're looking at tolerability, which is good, you're looking at Tmax, which comes in very, very early. You may or may not, it seems to have a lower impact on meal compared to sildenafil, and a lower side effect profile. So overall, if you would look at it, it's a safe, quick acting PD5 inhibitor recommended for men with ED. It has a lower side effect profile. It may be used in dosages such as 50, 100 or 200 milligrams in an on-demand indication, and ideally used once a day. We've seen it in studies being used even twice a day with an onset of action as early as 15 minutes within consumption of the dose. Thank you very much for your kind attention.
Next speaker will be Dr. Pramod Krishnappa. Dr. Pramod Krishnappa is a well-known andrologist in Bengaluru. He is a consultant and head of Department of Andrology in the Department of Urology at NU Hospitals, Bangalore, India. He is also a European Society for Sexual Medicine Penile Implant Fellowship obtained in Madrid, Spain. He has got European Urology Scholarship Program in penile reconstruction under Dr. Rados Dinovic in Belgrade. He is a visiting andrology fellow under Professor Craig Niederberger of the University of Illinois at Chicago. Dr. Pramod Krishnappa will now discuss with us comparing the various PD5 inhibitors available in the Indian market. Dr. Pramod Krishnappa, please.
Thank you for the introduction, sir. Okay, I thank the SASM for this opportunity. Today, I will be discussing about the various PD5 inhibitors and their different characteristics. Currently, what we have in India is all these which are mentioned here: the sildenafil, tadalafil, sildenafil, and the vardenafil. Sildenafil, it got the FDA approval in 1998. Most of these are discussed by Dr. Vineet sir. And tadalafil, My slides are not moving. Sorry for that. Okay. Yeah. So tadalafil gained FDA approval in 2003.
Can you please reshare the slide, sir?
Yes.
Yes, sir.
Yeah, I'm really sorry about this.
Yes, sir. It is visible now.
Yeah. Okay. I'm really sorry for that. Yeah. So and then the next Udenafil, it has not received the FDA approval, neither the European Medical Agency approval. It received approval in India in 2011, and then the other drug is the Vardenafil. It received both FDA and EMA approvals, and in India it made its entry in 2018. But I personally do not have any experience in the Vardenafil and the Udenafil. And Avanafil, although many of the Indian pharmaceuticals were manufacturing it, but the license was only to export these to the European Union and not to be supplied for sale in India. So coming to the indications of the PDE5 inhibitors, theoretically, there are all these indications, starting from the cardiac dysfunction till it can be used apart from in the sexual dysfunction, in psychiatric disorders, in urinary tract symptoms, in ureteric colic, and so on. But I will be restricting my talk only about the role of PDE5 inhibitors in the male sexual dysfunction. And PDE5 inhibitors are used in the most commonly indicated, that is ED. We all know that. It has also a role in premature ejaculation and also in Peyronie's disease. The role in premature ejaculation, there have been papers which have shown that it has a role. And also in Peyronie's disease, there are papers coming up saying that a low-dose tadalafil could help in the scar modeling in Peyronie's disease. And this is a recent paper published last year from John Mulal showing the different showing the different prescribing patterns in the United States. So as you see here, the most common drug prescribed still continues to be sildenafil. The next is tadalafil and the vardenafil. Of course, the avanafil details were not included in this. And this table shows that patients who are on sildenafil, they are less likely to change over to a different PDE5 inhibitors when compared to the other two PDE5 inhibitors. And I do not want to include all the 4 PDE5 inhibitors in one table. And you already seen that through Dr. Vineet's slides. So I took up just 2 PDE5 inhibitors, which are very commonly used in India, sildenafil and the tadalafil. So the peak efficacy is at 60 minutes. And for the tadalafil, it's around 2 hours. And tadalafil, the added advantage with the tadalafil is that it can be used as an on-demand and also as a daily dosage. And the efficacy is slightly prolonged with the tadalafil. And advantage of the tadalafil is that there is no any, the efficacy is not reduced with the fatty meal. And in those elderly patients who have concomitant prostate symptoms and erectile dysfunction. So tadalafil can be used in such individuals. So this is a meta-analysis paper where they studied the cost effectiveness. So this one showing the efficacy, where they noted that this paper has included all the 4 PDE5 inhibitors, including the avanafil. This has noted that the sildenafil 50 mg is the more efficacious. And when it comes to adverse events, it mentions that the avanafil has the least adverse events. And compared to sildenafil and tadalafil, definitely tadalafil has least adverse events compared to sildenafil. And what this meta-analysis concluded is that, so when somebody who wants to prioritize high efficacy than sildenafil, if somebody is worried too much about the adverse events, then it said that tadalafil would be a better option. This is they have done the cost effectiveness, so hence this was their conclusion. And there are also papers where they have assessed they've asked the female partners, which drug do you feel, which PDE5 inhibitors was better? And this paper said that many partners preferred tadalafil over sildenafil. And this randomized trial, which compared sildenafil 50, 100, and tadalafil and vardenafil, what they basically concluded was that the treatments, the benefits are almost the same. A small deviation that they noted in sildenafil was that the peak systolic velocity on the penile Dopplers was slightly higher with the sildenafil when compared to tadalafil and vardenafil. And there are also papers from Asian countries saying the use of combined PDE5 inhibitors. In fact, I also personally give combined PDE5 inhibitors in some of the cases, wherein this paper said that low dose of tadalafil and an on-demand sildenafil versus they have compared with the daily dosage, small dosage of tadalafil. This paper basically said that the better improvements with the combination and no any additional adverse events were noted in the combination group. And regarding the choice of the drug, again, one needs to decide based on the frequency of the intercourse. If somebody says that he goes to his house or he visits his native place where his wife is staying, he visits only once a week on the weekends, or he visits once a month, he's working in some city and he goes to his house only once a month. In such cases, you may give a sildenafil. And if somebody has a lower urinary tract symptoms, then you can prefer a tadalafil. And at the end of the day, it's always a patient's personal preference, whichever does best to him, so he can continue the same. And regarding the cardiovascular safety, at least still when I was in MBBS and during my MS surgery days, the notion that I had was to prescribe a PDE5 inhibitors, I need to get a cardiologist approval, which is not so. These have been studied enough and they are well tolerated and a good safety profile. The contraindications are that it shouldn't be given in a patient who has had an MI in the last 6 months, or whose resting BP is less than 90/50, or somebody who has a severe cardiac failure. And of course, the nitrates still continue to be the absolute contraindications. And you have started somebody on a PDE5 inhibitors and somebody is not responding. What could be the cause? I don't want to go into the details of this because Dr. Karthikeyan and Dr. Raman will be covering this. One specific note that I would like to make is the up to 77% of these PDE5 inhibitors that are bought online may be fake, and many of them, they do not contain any of the active drug component in that. And when you ask, around 50% of them discontinue this after a year. And if you ask them what is the reason for discontinuation of the PDE5 inhibitors, many of them, they say this partner-related problem, either the partner was not happy or because of the comorbidities or the cost was high. And some say it was not, the drug was not efficacious. And some say, especially in case of psychological ED, they say my ED recovered. And some might discontinue due to the side effects. And also there are a few brands which are which have a dispersible component in that. I personally do not have any experience in that. What they claim is they have a faster action and they don't need a water to be taken. And this paper said that it has a rapid onset of action, but I personally do not have any experience on this rapid release tablets. So adverse events, sildenafil, the most common that I see is again flushing. And when it comes to tadalafil, the most common side effect that I get is a backache. And our own, one of the SASM's very active member, Dr. C.S.S. Rao, also published a case report saying that where he had treated a patient who was taking 1,300 mg of sildenafil, and he had taken it for many years, and he was doing really, he was doing well. So these are well tolerated, and majority of them do not have any major side effects. And yeah, and there was an initial anxiety that this long-term sildenafil could cause some eye issues, but again, there have been many studies and review articles saying that the visual system, there are no any effects on the visual system with the sildenafil. And the PDE5 inhibitors do well if also coupled with psychosexual counseling whenever necessary. And as a take-home message, lifestyle modification should be given the first priority, like quitting smoking or exercises. And PDE5 inhibitors, sildenafil 50 mg, my suggestion is not to start with very low dose 25 mg, because the patient might lose the confidence on the drug when you again want to increase the dosage. That's my personal suggestion. So minimum dose to start a sildenafil would be 50 mg. And you can start a tadalafil if somebody is too much concerned about the adverse events and who has some associated urinary tract symptoms. And we in India, we do not have any experience about the Avanext. We'll have to wait for the results. And also discourage the patients to buy the online PDE5 inhibitors, because majority are fake. And a referral to the andrologist may be necessary if some of the primary care physicians are not well versed with the intracavernosal injections, vacuum device, or the penile implant surgeries. And of course, wherever required, please do take the help of the psychosexual counselors. Thank you.
Now I request Dr. Rupin Shah sir to please introduce our next speaker, Dr. Raman Tanwar.
So I'm sure that there must be many questions that everyone has, but we will be taking them at the end of the third speaker of this session. So the third speaker we have is Dr. Raman Talwar, who will be addressing the doubts in your mind that if there's so many PDE5 inhibitors, which one should we use? So he's going to give us practical tips, and Raman is very well qualified to give us this insight. He's the chief andrologist at Eurocenter. He's had training in andrology in Vienna and Naples. He was a fellow of the International Society of Sexual Medicine, a fellow with the European Society of Urology. He's been very actively involved in teaching programs of the USI. He's been on the guidelines committee. He's a member of the andrology subcommittee. So he's very actively involved in teaching and instructing. And we look forward to a very practical talk from Raman. Raman, over to you.
So first and foremost, thank you, Rupin sir. It was indeed a privilege to be introduced into this talk through you. And the motive of today's talk, of course, is to talk about what drug we have to start and in which patient. So unfortunately, there is no one drug which works on everyone. So that's why we are having this talk. And my job has been made much easier by my previous esteemed speakers, Dr. Vineet and Dr. Pramod, who are both very, very dear to me. And the outline of this talk is that we are basically going to address various issues. I think when we go and we want to buy a suit and we go for something that fits us well, the tailor would take the dimensions of your arms, the shoulders, and lot many places. And then he would show you various fabrics, and he will show you various threads and various buttons. And then you choose from them but you often are not so well versed with the material, so you ask the tailor also to make the choice. In our medicine also, we are also a tailor, but we have a much more extensive knowledge about the subject than the patient because of our years of training. And that's when, making the choice becomes more difficult because the responsibility lies on us. Now, there are certain measurements that we also have to take, just like the tailor has to take those measurements. So I think what is more important here is which patient we are going to give the medicine to. What's the age of the patient? What is the requirement of this patient? Does he need it daily? Does he need it off and on? Is he married? Are there any problems that this patient has? Because as Dr. Vineet and Dr. Pramod already discussed, that PD5 inhibitors are not something which can work for everyone very well. There are certain contraindications that we should be aware of. Does the patient have some history of a past usage of these medicines? He may be already biased with a few things. What is the degree of his erectile dysfunction? Is it severe, or is it just something which is just a starting and some little dose will work? Is there associated ejaculatory dysfunction? Is there a low libido? Do you think there could be hypogonadism along with it? What is the economic status of the patient? I think these are the very basic things from the patient's perspective that we should be knowing about. Now, the next is, which medicine should I give to this patient? Should I give a nutraceutical? Should I give sildenafil? Should I give tadalafil? Should I give vardenafil? Should I give sildenafil, mirodenafil, avanafil, SERMs, testosterone combination? What can be given to this patient to suit him best? Then the next third question, which is important to answer and which we will be trying to answer in this talk, is if we should be giving a low dose on a daily basis, should be giving something on demand, should it be the highest possible dose initially, or it should be higher than what we can actually give or are allowed to give? So all these questions also, on the dosage are also very important. And lastly, we may also think about which formulation to give. Does the client really need a suit? Will he be better with a jacket, or will he be needing a raincoat? So all these kind of things also are in the question. So maybe a pill, a mouth dissolving pill, or a strip. What works best? That is something we need to understand. So I think this slide has already been very well covered by my previous speakers, wherein we have this comparison. But why we are bringing this up again and again is because this is the basis of the talk. This is the basics that we need to be aware of. Right? So let's talk about the journey of this pill. When you will be giving it to the patient, what will be happening is that he's going to take it and then it's going to get absorbed. It's going to get ingested. So we have to understand that meal will interfere with this pill. So if there's somebody who just needs it after party for recreation and he's going to be full stomach, you have to be careful when you're giving drugs like vardenafil or sildenafil. You can give them tadalafil or avanafil because both of them are okay when you take it with high fatty meats. The second thing that you need to ask the patient and also ask yourself is basically, is the patient already taking some medicines which could be affecting the chief metabolic pathways of these medicines? So we'll be discussing a slide in the end where we'll be talking about these medicines, but you have to take this drug history. That's an absolute must. Now, thirdly, we need to understand how the drugs is getting eliminated. So as we know, most of the PD5 inhibitors, or rather all of them, are having a hepatic metabolism, and the renal excretion is very, very less. So we have to understand that certain medicines like sildenafil and vardenafil, they have a very high and extensive first pass metabolism, which means once you take them, once they are absorbed in the stomach, as soon as they will reach the liver, a lot of them will be already cleared by the liver. So, there will be a very low bioavailability for many drugs. And for patients who have a bad liver, you may have to taper the doses, maybe even reduce the doses a bit. Next, coming on to the potency and the selectivity. So selectivity and potency, again, as we know that sildenafil is something which has been said to be the most superior and the most potent. That's why it becomes a drug of choice for many of my patients. And vardenafil, which we don't have with us so widely, we are not exposed to this, but that's again something which has been thought to be very, very potent. We have to be aware of the cross reactivity of these because there's a side effect profile which will be created. For example, with PD6, there will be some effusion problems when there's cross reactivity. And then with PD11, 1 to 3% patients taking tadalafil will have body ache and myalgia. So we'll have to understand if these are going to be bothersome for the patient, or the patient has already got some visual problems or disturbances. So this is the slide that I was talking about. These are some of the common things that we should be aware of when we are prescribing these phosphodiesterase inhibitors to the patient, and we are trying to figure out which one to give and in what dose to give. So of course, if the patient has been on nitrates or alpha blockers, we know that these are gonna cause a hypotension. So we have to be very, very careful, and most likely for nitrates, we have to not allow the patient to take these medicines. Similarly, if the patient has been on antifungals or antibiotics like erythromycin, clarithromycin, in these kind of situations, or HIV medicines or cimetidine or grapefruit juice, these are all things which can actually delay the metabolism, and that therefore the patient will require a little less dose of phosphodiesterase inhibitors. Similarly, if the patient has been on rifampin or phenobarbital or phenytoin or carbamazepine, then the patient may require a higher dose because the induced effect of these drugs on the cytochrome enzymes is going to cause some problem. Similarly, patients with renal insufficiency and with hepatic insufficiency, these patients are also requiring some dosage change. We will discuss about them quickly in the slides. So the heart of the matter is that if you have a patient who is being a heart patient, and as Dr. Pramod told, we have to be classifying these patients. But the important thing is, if any of a patient is taking nitrate, then the nitrate has to be stopped. And the best drug of choice for me in these patients would be something like Avanafil or sildenafil, which is rapidly cleared from the system so that the patient can start nitrate resumption early. Because if we put such a patient on tadalafil, then we'll have to wait for at least 2 days for him to restart nitrates. And with sildenafil and avalafin, he can start nitrates as early as 12 hours. So this becomes important. If my patient is on any antihypertensives or alpha blockers, then again, it becomes very important for me to make sure that I give something like tadalafil, where the alpha blocker that this patient is taking is preferably tamsulosin, because with others, the effects are not very well known. They are yet to be studied. Similarly, if my patient is an elderly, then I know that his metabolism is going to be slow. So we will want to start with something lower so that we can have the same bioavailability eventually. Similarly, if my patient is a hepatic patient, then also I have to ensure that we have a lower starting dose for these patients, especially when it's sildenafil or vardenafil. With tadalafil, I can still start him on the right doses that I want to. So just to enlist these comorbidities, I want to ask in particular about heart problems, about hypertension, about lower unit tract symptoms, and if he's taking alpha blockers, about migraine, because sildenafil can potentiate, but at the same time, it can really help because the migraine won't last long because it will be cleared very well from the system. If the patient has any renal comorbidities, hepatic comorbidities, or any prior visual or auditory problems, because that's where, again, I don't want to give sildenafil to the patient. So one of the very good studies that have come up earlier has in the last decade have been the giving choice to the patient. So we give a lot of PD5 inhibitors to them and allow them to try so that the compliance is high. So this is also one of the strategies. So now let's come to what I will do. So I would like to prefer sildenafil in a patient who is the younger patient, because there we want something very effective. We don't want the patient's fate to be shattered, and he's most likely having a psychological erectile dysfunction where a good potent medicine can do wonders in improving his self-esteem, and he will not need to continue those PD5 inhibitors, probably because he will find that his erectile dysfunction has been cured. Similarly, I would like to give sildenafil to a patient who is on a one-time situation, one night at a time situation, somebody who has occasional sexual appetite or occasional opportunity to have sexual intercourse. I would also like to give sildenafil as an add-on to somebody who is taking a low dose tadalafil with poor response, or good amount of tadalafil with poor response. Also, because it's the most potent, so I would like to give my patient sildenafil as a drug when others are not working. I would want my patient with migraine also to probably have sildenafil because it is rapidly cleared. So if he has migraine, it will go off very soon compared to the tadalafil, where it could last theoretically for days till the tadalafil is cleared, and that may take up to 5 days also. Similarly, any patient who has a pulmonary artery hypertension, where this drug was actually made for, somebody who has also got a premature ejaculation, he's been taking depositing, because this is an important point, because sildenafil's pharmacokinetics would be very similar to that of depoxiting. So it will be a very jovial dosage for them if they have premature ejaculation. Also, somebody who has a low socioeconomic status, I may like to prefer sildenafil or tadalafil just because of the cost factor. For tadalafil, I would say tadalafil is my workhorse. This is the medicine which I most commonly give to my patients. And because of the very simplified dosages, it's less contraindications in most patients. I usually use it also because it can be given for the weekend in certain patients if they want a weekend demand, if the patients are on some sort of a chronic therapy, if the patients have lower urinary tract symptoms, if the patients have been undergoing dialysis, and if I am putting those patients on penile rehabilitation, especially those who are undergoing a radical prostatectomy or have undergone a radical prostatectomy. For Avanafil, I am yet to say something, but I think Avanafil is going to be a very suitable choice for those who have side effects. It's going to be a very good replacement for sildenafil in patients who want a faster onset of action and those patients who probably want to resume nitrates faster. So I think Avanafil is going to be a very special molecule, which is, which is going to take a lot of heat away, a lot of space that sildenafil has created for itself. Coming to the question of dosage, I would like to start patients on low dose first. If these are patients who have a hepatic impairment, if they are patients who are taking some medicines which require low dose to be started first, as we discussed in the earlier slides. If this is a patient with psychogenic erectile dysfunction where we don't want to give a lot of side effects to the patient, at the same time we want to preserve the efficacy, so we choose something like a 50 mg sildenafil rather than a 25, and also avoid 100 mg sildenafil. Also for the elderlies where the metabolism is slow, where the patient has lower urinary tract symptoms, because I don't want to potentiate any hypotension in these patients, and also in patients who are going to be on a daily dosage of medicine. At the same time, I may like to prescribe something higher for patients who have had poor relief earlier with medications, patients who have higher distress, or who are taking drugs which are increasing the metabolism. So in these patients, I may want to start a combination therapy, or I may like to give a higher dose. Now, basically talking about the outline again. So a younger patient probably gets sildenafil. Somebody who is not married probably gets sildenafil. Somebody who has comorbidities probably gets tadalafil. Somebody who has a history of past usages probably would get tadalafil or something in higher dose. Depending on the degree of ED, again higher dose. Associated sexual dysfunction, probably sildenafil, because it will correlate with depoxetine if the patient is taking depoxetine. Economic status, again, I would prefer something like sildenafil or tadalafil. Which drug? So we've already heard about that in detail. Which dose? So again, depending on whether it's on a chronic use, whether the patient is not sexually active or routinely sexually active, or how the response has been to these medicines. So depending on that, the dose would be there. And patients who require everything very fast, I would like to probably use mouth dissolving things or strips for those who want to use something on demand. So I hope this has answered a lot of questions about choosing the right medicine and choosing the right dose for the medicine. But again, this is not a one size fits all store. And we are the tailors and the patient trusts us. And so we have to give everything from the best of our abilities when we are making that small decision for the patient, because it could end up in a big way. Thank you so much.
Thank you, Dr. Rama. So may I request Dr. Narayan Reddy to introduce our moderators for question and answer session.
Thank you, Dr. Tanwar. Next, we'll have a discussion about this topic, and it will be moderated by Satya Srinivasan and Dr. Vinod. Dr. Vasan does not require any introduction because he is star of the day. Anyway, for formality's sake, let me introduce him. He is CEO and Medical Director, Ankur, Bengaluru, India. He is Head Andrology Fellowship Program at Bangalore. He is a teacher at Rajiv Gandhi University for Health Sciences, Andrology. He is a co-founder of Janani, a startup transforming fertility management. He is the president of South Asian Society for Sexual Medicine. He is member Stem Cell Task Force of Indian Institute of Science, and he has got a lot of patents, industry project, IBAB, ONOA, RNA transcriptions to assess presence of sperm in non-obstructive azoospermia, and microfluidic magnetic bead base separation of functionality, etc., etc. And is also going with the government, like Make in India projects, design, development, evaluation for biomedical application, sector under Ministry of Human Resource Development, Government of India. Dr. Vinod is the other moderator. Is a urologist and andrologist in Cure and SK Hospital and Fertility Research Center, Thiruvananthapuram, Council Member, Urological Society of India, Honorary Treasurer, South Asian Society of Sexual Medicine, Member, Guidelines Panel on Male Infertility of Urological Society of India, Member, Andrology and Men's Health Subsection of USI, contributed chapters in 2 books, delivered talks as faculty in various national on conferences and CMEs. Dr. Vasan and Dr. Vinod, please.
Thank you, sir. And thank you, Rupin and Deepak Jumani and Professor Dr. Reddy for this introduction. I think me and Vinod will take the questions. There's a lot of questions on the online, and we will go through as much as possible. So the first question I'm going to ask Vineet, sildenafil and tadalafil combination, how can it be scheduled and in which patient?
So I think this is something which Raman already addressed in his talk, and I think also Pramod to some extent. The point is, when you are going to be using a 5 milligram dosage of tadalafil as a daily dose, and you're looking at a patient who has a need which is intermittent, he has an adverse event profile which does not allow him to take a higher dose of tadalafil, or a efficacy or an adverse event profile which does not allow him to take a higher dose of sildenafil, you can then put them into the daily dosage of 5 milligrams of tadalafil and give on-demand sildenafil. This is one group of patients. The other group of patients that I have used this is on patients who have lower unit tract symptoms and have a concomitant ED, where a 5 milligram dose of tadalafil, if it is not effective enough for his erectile dysfunction, with an on-demand, because an older patient may have far more infrequent episodes of sexual requirement, may use an on-demand sildenafil at that point in time.
So basically, you're recommending a low dose of tadalafil along with the appropriate dose of sildenafil, depending
Yes.
on. We will alternate these questions. I'll ask Vinod to ask the next question from the chat box. Go ahead, Vinod.
The next question is to Vineet itself. There is a question in the chat box. It is written by Dr. Taneja from Alvar. See, in Avanafil, the side effect profile is supposed to be better, but if you look at the side effect profile, you have everything which the other PDE5 inhibitors are having, and there is hearing loss is also described. So it is a question verbatim I have given to you. So what is your comments on that?
No. So I think that's something that I mentioned in the talk. The adverse event profile is similar. The severity is much lower, and that's something that's shown in the talk that Raman also presented. So you're going to see a far greater specificity, selectivity. The PDI, if you saw that particular table, the selectivity of Avanafil for PD5 compared to a PD1, PD6, PD11 is much lower. So even though you have the adverse event profiles, but you have them in far less severity and incidence, which is why tolerability wise, it is clearly shown that it is more tolerable.
Okay, Vasan sir.
But the next question is, Rupin, I think you might have to take this one. Theoretically, of course, we don't have much experience, I understand, with Avanafil. Can we combine sildenafil with Avanafil, considering their pharmacokinetics for better efficacy?
It probably doesn't make sense to combine them. You want to combine two things which have a different pharmacokinetics. So when we just spoke about tadalafil, sildenafil, that made sense. But sildenafil, avanafil, combining them doesn't make sense.
Go ahead.
Sir, Rupin sir and Vasan sir, is there any sufficient studies to show that the combination is good of two PD inhibitors?
Okay, I'll tell you from practical experience. What happens is we have a young man where we think that the problem is primarily psychogenic, and there's a good chance that with just 5 mg tadalafil, he will do well. So I don't believe what a lot of people do, that giving 5 milligrams tadalafil every day is therapeutic and it'll cure ED. I don't think that is true. But in a man with psychogenic ED, you give him 5 mg tadalafil in the hope that that alone on daily dosing will get him back to normal sexual functioning. But because initially he may have extra anxiety, as a backup, you tell him keep this 50 mg sildenafil with you, so that will give you the erection at the time of intercourse. So it is in that context that we combine the two.
Rupin, just to add to that question, is there a role for reducing the adrenergic tone? Obviously, these patients are not responsive to that dosage because of high adrenergic tone, especially because of anxiety. So is there a role for any of these beta blockers?
Not beta blockers, but people have actually tried oral phentolamine in fairly high doses, but it was not effective. Where we see the blockage of adrenergic tone being very useful is when you give an intrapenile injection with a bimix. So you might have a patient very anxious, 100 milligrams of sildenafil, not effective, and a small dose of bimix, piperine, chlorpromazine, will give him a full erection, because the chlorpromazine component, like phentolamine, is an alpha adrenergic blocker. But since you've asked the question, do you have experience with a beta blocker for that purpose?
I have used propranolol, and especially in these kind of instances, and some of them do respond very well. And,
because theoretically, a beta blocker may actually cause ED.
Erectile dysfunction.
That is a question from the chat box also. If a patient is on beta blocker and is having a ED, how do you manage?
Switch to nebivolol.
No, first is to stop the drug and see whether the stoppage of the drug itself reduces the ED or this thing. Usually, when you stop, you need to wait for at least 2 weeks period. And if it doesn't, then you start him on a PD5 inhibitor. The first thing is to stop the drug and see.
Dr. Deepak Jumani, is nebivolol going to help?
If at all he needs beta blockers, the ideal beta blocker is nebivolol.
The next question is to Raman. Does sildenafil 20 milligram in pulmonary artery hypertension increase libido or erection? Somebody has written thrice. I don't know what it means by thrice.
So basically, I was while preparing the talk, we did a lot of reading around it. So patients who are on sildenafil for PAH, they of course get benefited in erections when even if they are taking 25 mg of sildenafil on a daily basis, but the efficacy would not be as good as probably a 50 mg. As far as libido is concerned, I couldn't encounter any such papers where libido was also measured as one of the criteria. So I think I will not be able to answer it theoretically. Also, practically speaking, I think libido would not be affected as such with sildenafil. Just the ease of having an erection and the increase in libido arising out of the confidence of being more confident during the act probably would contribute.
Next is to Dr. One of our colleagues is interested in knowing about the role of PD5 inhibitors in Peyronie's. You have mentioned in your talk, it can be used in Peyronie's.
Yes, sir. Sir, 4 years back, Eric Chung from Australia, he did a lab study, and he did it on the rats and other. I don't remember the exact animal. So basically, he found that there was improvement in the scar remodeling in the Peyronie's disease. So then the papers are coming up saying that even in the European guidelines also, it has been added now. The tadalafil has been added. Although the evidence is weak, 5 mg tadalafil daily for 3 months is being given nowadays for acute phase of Peyronie's.
The next question is to Dr. Reddy. Considering the wealth of experience you have, and you see a lot of patients with both organic and psychogenic, where do you think Avenafil will be the first line of treatment? Which group of patients you would be happy to start them on Avenafil?
And as clearly explained, when you give tadalafil and the client gets a problem, especially a cardiac event, then we are stuck. We have to wait for longer duration. That way, both sildenafil and avenafil, which are short acting, they'll be much more useful. So you have to ultimately judiciously decide what you can do. So ideally, it is better when you take history, whether the patient is going to prone for any cardiac complications or not. Only later on, after finding that out, you decide which type of drug you are going to use it.
Sir, just to add to that question, would you prefer this over sildenafil in your psychogenic patients, considering that it is faster and lesser side effects?
It is clearly said, if it is psychogenic, you go through other way. But Rupin very clearly said, tadalafil 5 mg definitely is useful even in psychogenic erectile dysfunction.
Sure.
Sir, next question to Rupin sir and Vasan sir. See, we are discussing a lot about the cardiovascular effects of PDE5 inhibitors. Now, even if one of our patient on PDE5 inhibitor is having a cardiac event, I think now the cardiologists are seldom giving sorbitol nitrates. They will be giving nitrates like if they are having a hypertension, they may give a nitroglycerin. In that case, they are looking for a low BP. They are trying to put the patient on a low BP. So will it be a real problem in nowadays? I don't know the cardiologist version of it. Because one of my patient who is a doctor who had who was on tadalafil had a cardiac event, and I immediately spoke to the cardiologist and they said we are no more giving nitrates, so no need to worry about that. So what is your take on that, sir?
So that is good news if they're using less nitrates, less chance of complications. But your other question was that if you do take the nitrate and the PDE5 inhibitor, there'll be some fall in BP, but they want the fall in BP. That is a problem because the fall in BP, when you combine the two, is very profound and very difficult to reverse. And in fact, we've not seen it, but in literature is mentioned that such people will need an intra-aortic balloon and really extreme measures to maintain their blood pressure. So if it's not being used, very good. But if it is potentially in use, it should not be combined.
The next question.
In one minute. In case if patients who are wanting to use PDE5 inhibitors and are on nitrates, studies show that they can switch over from nitrates to another drug called ranelozine, which is equally effective as nitrate in dilating the blood vessels of the coronary arteries, but has got no effect on the blood pressure. So studies have shown that ranelozine is another choice for patients who are on nitrates and who also want to use PDE5 inhibitors.
Cardiologists have been prescribing 25 mg sildenafil citrate for pulmonary hypertension. Can avenafil be used same way?
No studies yet, sir.
Question, Vineet. Your comments.
For the use of nitrates versus
Avenafil in pulmonary artery hypertension.
Just like sildenafil.
I don't think there will be any change on that. The usage would be similar to what sildenafil is because the profile is the same.
But I think there are no studies so far done.
No, I actually did not come across any of the Avenafil papers for pulmonary arterial hypertension. So I would assume that it would have the same pharmacokinetics.
The next question is to Deepak. We'll have to rush through. There are a lot of questions. What is the cost of Avanext and how easily it is available currently?
Avanext 100 mg is costing around 86 or 87 bucks, and 200 milligram is costing 167 rupees.
And what is the minimum pack size they have to buy?
I think the pack of 2.
And
Next.
go ahead, Vinod.
Next question is to Dr. Pramod. What about premature ejaculation and PDE5 inhibitors? Do you have a choice of PDE5 inhibitor for premature ejaculation?
There is no specific choice, sir. Usually, use sildenafil low dose. Sildenafil short acting should be fine. So basically, they need to take the PDE5 inhibitors and they need to do the stop-start technique to get over the premature ejaculation. Because when we advise stop-start technique for PE, they say that I lose my erection. So in such cases, this PDE5 inhibitors will act. No specific choice, but I would prefer sildenafil in most of my patients for PE.
I have an idea that means as and when a patient develops erectile dysfunction, his symptom will be premature ejaculation. In such cases, sildenafil or any PDE5 inhibitor can cure for this premature ejaculation. Actually, we are treating erectile dysfunction. Patient will not be knowing that. In the initial stage, each and every patient's complaint will be premature ejaculation. When ED develops, premature ejaculation is the first symptom.
So just to add on that, the PME, premature ejaculation, is an extension of the anxiety group of disorder. So you need to treat the baseline anxiety of the patient first. So here we can apply the SSRIs which cause delayed ejaculation. As an adverse effect being used in a therapeutic profile, we can use the fluoxetine or the paroxetine. That is very helpful. Apart from that, that has already been mentioned that the stop-start technique, squeeze technique, these are the behavioral approach that also help.
I agree, but the point is that suppose a
How
40
useful
years
is Avanext in the treatment of premature ejaculation?
I do not have any
Because I saw one of the slides mentioning that.
I see. No, what I am saying, that means as and when a patient develops erectile dysfunction, his complaint may be, consider the age of 40 or 45, his complaint may be premature ejaculation. In such cases, PDE5 inhibitor will work. It is my own experience.
Pramod, do you have any take on using Avanext for ejaculation?
Sir, no, sir. I have no information about the Avanext.
This is a patient who's posted a case here. Anybody can take this. My patient is a diabetic type 2. 10 years he's suffering from ED. The penile Doppler shows zero flow. What to do? Is it, would you consider drug therapy? Would you consider surgery? Or is it implant surgery or a microvascular surgery?
Actually, it's a fairly straightforward problem. PDE5 inhibitors are not going to work. Intracavernosal injection may work if you use Bimex. Pure papaverine will definitely not work. If the Bimex works, he can go on to self-injection. Otherwise, he needs an implant. There is absolutely no role for revascularization in a patient with diabetic microangiopathy.
Agree, sir.
Next question is
so,
about
just to cut out. So I think we are short of time. So can we just move to next section?
Last question, let him finish, and then we will close.
Okay. Okay. Thank you.
Yeah. Next question is about combination therapy. Not between two PDE5 inhibitors. It's with the PDE5 inhibitor with arginine and also with the testosterone. I think Raman can take it.
So of course, there has been a huge role of both nutraceuticals and testosterone. Now, nutraceuticals, of course, can be prescribed to just about anybody, but then the dosage has to be between 1.5 to 5 grams of L-arginine. Less than that is not going to work as per most analysis. And preferably, there has been a trend that more than 3 grams or at least more than 2.5 grams is what should be given. but this is something that is very expensive, difficult for the patient to continue on a long term. The role of testosterone, I would like to say that if the patient has low testosterone, then definitely there's going to be a huge impact when you add testosterone to patients with erectile dysfunction who are on phosphodiesterase inhibitors. Rather, patients who are with the low testosterone and taking phosphodiesterase inhibitors alone, they would have a very poor response to these. Adding testosterone to them, definitely counseling the patient that it may take about 2 to 4 weeks for some effect to be seen. It is going to do wonders in the practice when it is done on the right patient.
Thank you. I think we'll close this question answer session, and I thank all the speakers and Vinod for joining me in this. And I hand over back to the Zydus team to start the next session. Thank you very much.
So I request Dr. Jumani to introduce our chairperson for next session.
May I now invite Dr. Shivam Priyadarshini, who is a senior professor and head of the Department of Urology, SMS Medical College, Jaipur. He's been the fellow at various reputed centers abroad, New York, University of California, San Francisco, Cornell Medical University, New York. He topped in MBBS from Kolkata University and was awarded gold medal and scholarships in medicine, surgery, and gynec. He is convener of USI National Guidelines on Male Infertility and a member of ED Guidelines Committee. He's a core member of the Andrology Subcommittee of Urology Society of India, and he's a president-elect of New Engines Chapter of Urological Society of India. I also invite Dr. Ajayan Varghese, who is a great friend of mine. He's a chairman of International Association of Sexual Medicine, Modern Medicine. He's a director of Institute of Sexual and Reproductive Medicines. He has been very active. His WhatsApp group is very active, and of course myself. Now we will please invite Dr. Shivam, please invite Dr. Karthikeyan, please.
Thank you, Dr. Deepak, for their kind remarks, and thanks, Zydus, for giving us this opportunity. So we discussed about the PDE5 inhibitors, the various types. Now the two most important topics that we have today in the next session is, one is in today's COVID era, is there any association between erectile dysfunction and COVID? We know ED is a hallmark for endothelial dysfunction. And even COVID infection has shown that there is some imbalance between the endothelial thrombotic and fibrinolytic activity. So in one of the studies, the author has rightly said that mask up to keep it up. So this is an important issue that will be discussed in this session. And the second important thing is that if the PDE5 inhibitors do not work or they fail, then what next? So for the PDE5 inhibitors failures, I will invite Dr. V.S. Karthikeyan. He is one of the upcoming young urologists and andrologists, and he is an andrologist who is working at Sri Narayani Hospital and Research Center, Vellore, Tamil Nadu. He did his clinical fellowship in andrology at Dios Men's Health Center under the mentorship of Dr. Vineet Malhotra. He also did a clinical observership at Miller School of Medicine, Miami, USA, under Ranjit Ramaswamy. He has a lot of publications. So Dr. V.S. Karthikeyan, over to you for PDE5 failures and what next.
Thank you, sir. Thank you, Sesam, for having me here. So the next topic will be why do PDE5 inhibitors fail and what to do next? So as we all know, the on-demand PDE5 inhibitors is the recommended first line of treatment, and we have been talking about this so long. The overall efficacy of a on-demand inhibitor is around 60 to 70%. But in around 30 to 40% of men, it is insufficient. And this failure can be more common in diabetes. So the usual scenarios which come to a urologist or specifically to andrologist are men who are not improving on PDE5 inhibitors. So a young man recently married taking PDE5 inhibitors, not improving. A fairly adult 45-year-old male who has a new onset ED which is not improving, and an elderly male where again with diabetes mellitus his ED is not improving. So in all these situations, the question we confront is why the PDE5 inhibitor has failed. So while we discuss this, we have to see the patient factors, the disease factors, and the drug factors. So most of it has already been discussed in the previous discussions. So what we will be doing here is we will be putting everything together and assessing what exactly has gone wrong in the patient. So the patient factors can be non-compliance to drug instructions, what the patient understands about the disease, whether, as we have been discussing the question answer session, whether he is having only PE or he is having ED plus PE, which is more on all those things. What is the performance status of the patient? What is his anxiety and stress level, which is probably making the PDE5 inhibitor fail? And the partner factors. Similarly, disease factors. What are the comorbidities? What is the severity of the disease? What is the control of the comorbidities like diabetes mellitus, etc.? What is the severity of the ED? What are the coexistent conditions and whether there are any previous operations which are contributing to this? And the drug factors, whether the patient has taken the right dose and the right dosage. So as we have been talking, we would have prescribed the patient 2 drugs, say tadalafil and sildenafil. But the patient would have taken only tadalafil and he would not have taken the sildenafil. So we will be thinking that the combination is not working, but in fact the patient has not taken the combination. Similarly, whether he has taken the correct drug at the correct time, whether the relation to food intake was followed, how many doses he was prescribed and how many he has taken, and what is the response during each dose. So all these things have to be taken care of. So coming to the complaints to the drug, whether the patient took the drug at the correct time and he has followed the number of prescriptions and he has not skipped any dose, whether he is still very anxious, whether he is not able to perform despite taking the drug, and the stress levels. So when we sort out these factors themselves, probably our PDE5 inhibitors will also start working. So what he understands by the disease, what does he think that drugs can do, and what will be the overall effect of the treatment, and the same questions from the partner side also. So as a couple, what they are expecting from the treatment. So when we discuss all these things, only then we will be able to find a solution as to why the PDE5 inhibitors have failed. Similarly, the severity of the ED, as we all know, it is due to atherosclerosis. If the duration of the ED is long and the disease is more severe, and there are associated conditions like peyronie's disease or venous leak due to any reason, in all these situations, probably the efficacy of the PDE5 inhibitors will be less. Previous operations also can contribute to the PDE failure. So the history regarding the previous operations like spinal cord injury, spinal cord surgery, urethral surgery, prostate operations, all these things also are important. Similarly, prescription drugs which can worsen ED can make the PDE5 inhibitor fail. So a careful drug history also is important while we are assessing PDE5 inhibitor failure. So coming to the categories of PDE5 inhibitor failure, there are 2 categories. One is failure of monotherapy and one is failure of combination therapy. Combination therapy can be either 2 PDE5 inhibitors or PDE5 with some other drug. So initial non-response, as we have been discussing, comorbidities, inappropriate use of the drug, and hormones, whether the patient is also having concomitant hypogonadism or hyperprolactinemia. So with respect to the drug, we follow the FAST protocol, that is follow up the patient, adjust the timing of the drug, whether there is sexual stimulation adequately, and titrate to the maximum dose, control of comorbidities and normalizing testosterone levels, either by exercise, diet, or even by supplementation whenever required, change the PDE5 inhibitors, and switching over to continuous PDE5 inhibitors. So these are the initial responses we take when we encounter a PDE5 inhibitor failure. So in this busy slide, I would like to focus on these things. So optimize the PDE5 trial. It has been shown that up to 8 attempts have to be given for the same PDE5 inhibitors. The same drug has to be started again with proper advice and prescription of the instructions which you are supposed to give with the PDE5 inhibitor. We reinforce the same. We reinforce the need for sexual stimulation. And in case it doesn't work, then we proceed to hormonal manipulations like testosterone therapy in any form, maybe tablets like clomiphene, etc., or by using anastrozole or testosterone, all those things. Second is the lifestyle modifications. So daily aerobic exercise of 30 to 45 minutes and loss of body weight. They have been shown to improve the efficacy of PDE5 inhibitors. So whenever we are having a failure of PDE5 inhibitor, it is also very important to bring in this aspect into the treatment. So even though we stress on this again and again, when we have a PDE5 failure, we again enforce strictly daily aerobic exercise and loss of body weight. So the options for failed PDE5 inhibitor when on-demand PDE5 fails is switching over the PDE5 inhibitor or a combination, androgen substitution plus metabolic optimization and lifestyle changes, topical alprazolam, and then further treatment modalities can be followed. So what are the strategies which we have been discussing? So as we have told, a new PDE5 inhibitor can offer up to 8% success because sometimes a different isoenzyme is blocked and that can improve, or sometimes partner prefers a drug. So there is an option of using a different PDE5 inhibitor and combination PDE5 inhibitor, similarly treating the comorbidities. And non-drug therapeutic approaches can salvage a PDE5 inhibitor failure in up to 30 to 50%, especially psychogenic counseling, partner's role, and of course, exercise and lifestyle changes. So before branding a patient as failure of PDE5, check if drug instructions have been followed, the maximum therapeutic dose and the optimal dose was given for appropriate time, whether he has had sexual stimulation while on the drug, and whether combination has been tried. So after all this, we now move on to metabolic syndrome ED, which is the more common cause of ED nowadays where failure happens. So one is the metabolic syndrome where there is endothelial dysfunction, and diabetes, again, there is cavernosal structure change and endothelial dysfunction. Here, the low-dose tadalafil helps in repairing the vascular endothelial damage, and sildenafil provides the hard penile erection, which is whenever required. So the combination drugs are L-arginine, that is one of the nutraceuticals which was just discussed in the question answer session. So in a study in diabetic men, when L-arginine was introduced, it showed that there was an improvement in peak systolic velocity, and the improvement in ED was also partly due to increase in testosterone levels. So there is with evidence in the literature that L-arginine can contribute to improvement in ED. Similarly, topical alprazolam around 300 mics, which has a different mechanism of action from the PDE5 inhibitors. So based on a paper, so along with the maximum dose of PDE5 inhibitors with topical alprazolam, there has been improvement in ED, and there have been some instances of priapism as well. So everyone knows about this mechanism of action. So the PDE5 inhibitors work by increasing the cyclic GMP, while the alprazolam works by increasing the cyclic AMP. So there are two mechanisms of action, and therefore there is synergy when we use these two combinations. So androgen supplementation, observational studies have shown positive synergistic effect, while randomized control trials have shown no additional benefit whenever we add androgen to either monotherapy or combination therapy, even in hypogonadism. So these are the RCTs which have been reported so far. There has been no much improvement when we add an androgen along with the PDE5 inhibitor. That is based on the literature. So coming back to what all we see when we talk to the patient regarding the drug. So that is the same thing, whether adequate time was allowed before the drug has taken its onset of action, whether the patient knows that the drug has to be taken at this time and then he has to start the act at this time. Similarly, how long the drug will act and what is the time to peak plasma levels. All this advice has to be given to the patient. So PDE5s can be too expensive. Because of that, the patient would not have followed the advice. That is also possible. So updose titration usually works in many patients. And when there is a gradual loss of responsiveness to PDE5 inhibitors, we have to work up for other medical conditions like increasing atherosclerosis, hypogonadism, etc. So this is the recent data which shows that combining PDE5 inhibitor with testosterone has been shown to favor combination therapy. There has been also a role of low intensity shockwave therapy, which can improve the responsiveness to PDE5 inhibitors. There have been other options like vacuum erection device, drugs like folic acid, metformin also have been shown in single studies that there is some effect in combining these drugs with PDE5 inhibitors. Similarly, when Patient has LUTS, hypogonadism, post-RP and monotherapy resistant ED. The studies favor combination therapy. So just to conclude, whenever we have a failed PDE5 inhibitor, in salvage, we have to assess the correctable factors, check whether drug instructions have been followed, whether comorbidities have been optimized, lifestyle modifications and weight reduction have been started, and aerobic exercise is very important. Switching over a PDE5 inhibitor, combination with 2 drugs or combination with other drugs with or without LISWT can salvage up to 30 to 35% of men who initially failed on PDE5 inhibitors. If all these options fail, then it is obvious we have to move on to the second line and third line therapies. Thank you for a patient listening.
So I would like to request Dr. Arjun Varghese to introduce our next speaker, Dr. Ranjan Bhattacharya. Dr. Arjun Varghese, sir.
So it is my duty to introduce Dr. Raman Bhattacharya. He is Associate Professor and Head of the Department of Psychiatry, Murshidabad Medical College Hospital, West Bengal. He is Director of Charak Square Diagnostic and Research Center. His special area of interest is sexual medicine, addiction psychiatry, child and adolescent psychiatry. He has published 52 papers. His awards are BPSSJ, IJCM Award, and Dr. R.N. Murthy National Award in the field of psychiatry. He is Life Fellow in American Psychiatry of Association, Indian Psychiatric Society, Indian Association of Private Psychiatry, and Indian Association of Geriatric Mental Health, Direct Council Member, Indian Psychiatric Society, Honorary Secretary of IMA, Berambur, and Assistant Secretary of IMA, Bengal State Branch. Over to Dr. Rajan Bhattacharya.
Thank you so much, sir, for your kind and generous introduction. Let me share my slide first. Yeah, thank you so much. So my presentation will highlight on the various psychological aspect of the sexual health, which is especially important during this COVID pandemic. I can recall the almost 60 years back, a famous song. The song was based on the movie that "Ae Dil Hai Mushkil Hai Jeena Yahan, Jara Hatke Jara Bachke." I would like to read from the last phrase. Ye hai COVID meri jaan. So for the last 18 months, we have been strangled here in this pandemic, and we are nowhere and seeing how to go and how to move ahead in general, and especially the sexual life has been jeopardized. So the sexual life and the sexuality encompasses a multitude of the phenomena which include the partnerships, behaviors, attitude, identity, orientation, beliefs and activities, so on and so forth. It also includes the various penetrative acts like vaginal, anal intercourses, oral sex, as well as the mutual masturbation. And a safe and frequent sex life is essential for the multitude of benefits, both physical and mental life. So at the outset, I would like to say a disclaimer that I have not been received any honorarium, and I do not have any conflicting of interest or conflicts of interest. And I would exactly summarize my presentation in the 10 minutes allotted to me by Kandarp and Sajal. So the presentation will be divided by like that: a brief case vignette for 2 minutes, evidence-based medicine 2 minutes, sexuality issues I will cover 2 minutes, proposed approaches and recommendation with another 4 minutes, and it will just enough for achieving the orgasm time required for a female counterpart. So my case vignette is basically based on a real scenario that has been already published in the European Society for Sexual Medicine's website. It's a story about a Roberto, who is a 30-year-old engineer who has been married with Anna, a beautiful 29-year-old teacher. They have been married for last 1 year. And on the anniversary, they went for a honeymoon trip, second honeymoon trip, and they were really enjoying a perfect life, nice working environment, quite a handsome salary. Just bought a new flat apartment, with well furnished furnitures. But on 27th February 2020, he and his wife started to have the mild respiratory syndrome. And after 1 week of the failed antibiotic therapy, they eventually consulted the local general practitioner, and RT-PCR test was advised, and they have been tested positive. And despite the symptom disappeared after 2 weeks, it's a very common phenomenon these days. He and his wife remained positive for the swab test for 57 and 64 days respectively. And both of them are quite frightened with this, the report, and they are very much frustrated. And unlike the Indian patient blaming to the doctors, they are pretty dissatisfied, and they were bewildered. What is the reason for that? And they didn't attempt any sexual intercourse during that period. And on the second month after recovery, Roberto noted that a dramatic decrease in his erectile function. Anna is also experiencing the lack of sexual desire. It's a very common hypoactive sexual disorder of women. And they discussed about the situation, and they blamed the strict quarantine measure and stress related to the still positivity. Nasopharyngeal swabs were attributed for this sexual problem. Thankfully, they have not blamed the doctors. The story of the Roberto and Anna is quite emblematic. And clearly, the stressful lifestyle is a factor known to impact the couple's sexual relationship. With this background of the case, Vignet, my presentation will highlight about the mental health implication of the COVID-19. And as you all know, we are seeing the lots of deaths these days. I talked with my CSU colleague who is working in the critical care, and they used to say that previously, before this pandemic, they used to see the 3 or 4 deaths, and now they are seeing almost 40 to 50 deaths per month. So this is very difficult for them to cope up, and bereavement, isolation, quarantine, lockdown, physical distancing, these all have jeopardized their mental health, and which is have a direct impact on their sexual health as well. Sexual health requires more attention, and as it has been affected in COVID pandemic, and prevalence of sexual dysfunction association with the various other mainstream psychiatric illnesses, which we call axis 1 illness like depression, anxiety disorders, stress disorders, have been well documented. This one is a paper that we have been doing, and it is in the pre-acceptance phase in a reputed journal about the sexual health during COVID-19 pandemic, its impact on quality of life. And this my co-author is the Dr. Chatterjee. And what we have done is that we have appended an online survey questionnaire in the Google form, and we send that to the different, not in the different WhatsApp group, we have sent in the broadcast message in order to avoid the biasing, because there is a chance of the selection bias and response bias. So we have sent in the broadcast message, and we have appended the questionnaire, and after getting the response and the time, we have done in the flowchart like that. It's an online survey. After getting the informed consent, which is appended to the Google form, the first page is related to the demographic data and the behavioral practices. Second one is the DASH scale, depression, anxiety, stress scale. It's a 21 item scale, 7 items each for depression, anxiety, and stress, and followed by ASEX scale, Arizona sexual experience scale. And finally, we have applied the 26 item WHO quality of life BRAVE version. And the time frame was the 2 months, started from the 1st June and ended with the 1st August 2020. And the significant finding of the SX code, you can see the strength of the sex drive. The sample size is quite good. 1,376 response we have gathered. And we have found that all the domains of the SX, like the strength of sexual drive, ease of sexual arousal, sex strength, as well as the penile direction and vaginal lubrication, and the ability to reach orgasm, satisfaction of the orgasm, all have been affected. Last one, the satisfaction of an orgasm, the p-value is significant at the 0.03, and rest are a significant p-value at the 0.000, quite significant. And when we applied the DASH scale, SX scale, and WHO BRAVE scale head-to-head comparison, we have found that the DASH SX comparison is also very statistically significant at the p-value 0.000 by doing the chi-square, and the DASH scale and the WHO BRAVE is also found to be significant. So the findings suggest that in summary of our studies, that a higher score of the depression, anxiety, stress, and the additional sexual experience are attributed, and they are also directly related to the poor quality of the life, as we have found in WHO BRAVE. Age, gender, marital status, education, family income, social distancing. I would like to frame the physical distance, not social distancing. Physical distancing is the appropriate term. Use of sanitizer, having COPD, CKD, dash total and SX total are quite highly significant with the quality of the life. Now coming to the other related relevant search I've made in the PubMed, and I found that one of the important studies that done by the Anna Fuchs et al. On the impact of COVID-19 on female sexual health. And the variable has been found in the female sexuality function index. We can see that the desire, arousal, lubrication, orgasm, satisfaction, pain, all the domains of the FSFI are significantly affected during COVID pandemic. And also the COVID-19 pandemic and the various variables in the form of the spending the more time with the partner, or the effects of the restriction or limitation of the day-to-day emotional relationship, sexual avoidance behavior towards the partner, considering that you are the infected of the intercourse. These are the domains that have been assessed, and significant domains that have been found are sexual avoidance, considering that you could be infected during the intercourse, that is keep playing in the background. And considering that partner has sexual avoidance behavior has not been found to be statistically significant. However, taking precaution during the intercourse, like wearing the mask, and increase in solitary sexual satisfaction approach like mutual masturbation or video or self-masturbation have been found to be statistically significant domain. And in the last domain, you can see the sexual frequency has been reduced as the pandemic progresses. So in another study, in other significant finding of this study done by the Turkey group by the Garagos et al. And they have also found that the different function comparing the IEF 15 scores and FSFI score. You can see on the left hand side that various domains of the functioning of the male of 148 males where the male subjects were included in the study, and the following erectile function, orgasmic function, intercourse satisfaction, and overall satisfaction are statistically significantly affected in male domain, and in the female, the lubrication, orgasm, satisfaction, and the total score have been found to be significant statistically. So across the globe, the various other aspects have been evolved, like online pornography has been increased dramatically and recently documented 24% rise in the viewing of the internet pornography during this pandemic period as found in the Goldenberg et al. And this may be due to various factors like increased home confinement. To cope with the stress, anxiety and uncertainty are prevailing all over, and to reduce the stress, they are watching the pornography, and to cope with the fears related to the death. Coming to the various other aspects like sexual abstinence and the coercive sexual practices or intimate partner violence and in sexual relationship, they have already found to be increased. And this study has been published in the Journal of Psychiatry by my friend Banerjee et al. That fear related to the intimacy, travel history of partners, uncertainty about the transmission, physical distancing, these factors are very important for the sexual abstinence, and history of the intimate partner violence, marital discords, and substance abuse, increased pornography use are quite significant factors which are attributed with the coercive sexual practices. The other findings like the unhealthy use of the technology, pornography addiction, use of the dark web, interpersonal issues, extramarital relationships, marital discord and harmony are the effect on sexual practices that have been evolved up during this pandemic, and the contributing factors for these are isolation, quarantine, history of substance abuse, externalizing personality traits like having conduct disorder, antisocial personality disorder, ADHD, compulsive use of technology, so on and so forth. Now coming to the effect of sexual practices like rise of sexual disorder like erectile dysfunction, premature ejaculation, arousal disorder, Dhat syndrome, these have all common disorders have been found to be significantly increased during this pandemic in this study. And these contributing factors are the pre-existing sexual problems, chronic stress, chronic abstinence, depression, anxiety, psychosis, interpersonal issues, and reduced self-esteem. Similarly, the proposed approaches in this abstinence is ideal and safest, but not always is practically feasible. Masturbation and self-gratifications are the other options that have been advised by the various groups of researchers during this to improve the sexual health in this pandemic. Coming to the getting the appropriate mutual consent is essential because the digital sex is an evolving concept that are coming up, and sociocultural acceptance is quite good, and its availability with the smartphone, sexual extortion messages and sexual details images and are various challenges as the cybercrime issues, consequences, cyber harassment, bullying are the emerging issues that are coming up, and the dark web is one of the trap that has been commonly used by this sex texting and sexual messages, implicit sexual messages
But that is digital sex is getting popular, as it has been evidenced by the number of hits in these websites. And common continuation of the usual activities has already been recommended, like the common practices, weddings, mask, hand and respiratory hygiene before and after intercourse, cleaning the place of the sexual intimacy, avoiding sexual behavior that can lead to the orophycal contact, and minimizing the contact intimacy and regulating the frequency of the sex if the suspect is at risk. So the recommendation, the fourth part of my presentation, that is the solitary sexual activity is recommended. Masturbation is allowed, it is safe, and may have the significant psychological benefits to reduce the tension and anxiety. The cohabiting partners advises that the sex with the asymptomatic cohabiting partner is safe. The sex should be avoided with a quarantine partner following infection or exposure. Sex should be avoided with the symptomatic carrier. And if the partner is at risk of severe disease due to background of morbidity, sexual activity should be allowed only if both the partners are staying at home. So there are other options like the sex robots are now available, and these have been gaining popularity in the Western counterparts. Partners outside the household, sexual contact with anyone outside one's household should be avoided. Non-cohabiting couples may stay intimate, and the virtual sex are being encouraged. About the multiple and new partners, has already been mentioned that the monogamy is like a beautiful garden, and the polygamy is just taking a risk in running or going through the bush. So sex with multiple partners and casual sex is firmly discouraged. Video dates, sexting, or chat rooms are feasible and safe alternatives. Kissing and oral sex. Kissing is allowed between the healthy, unexposed cohabiting partners. Kissing should be avoided with anyone symptomatic or with people outside one's household. Vaginal intercourse is allowed, as there is no evidence that the COVID-19 is transmitted through the vaginal secretion, and there's no RT-PCR technique to guide or diagnose the virus SARS-CoV-2 through the vaginal secretions. So talking about the anal intercourse is allowed, provided the fecal-oral transmission is carefully avoided. Analingus or rimming should be avoided, as the fecal-oral transmission of the virus has been documented. And encouragement to the virtual sexual activities like video dates, sexting, chat rooms, erotic phone conversation are the safe alternatives to sexual contacts. The last study that we have published in the Indian Journal of Community Medicine, and we have found that the youngsters are getting affected with the sexual dysfunction and the various comorbidities associated with the depression, as well as the nicotine dependence, the substance that we have covered in this study. So my take-home message is very simple, straightforward. Safe sex ideas during the pandemic would be the video chat, solo activities, mutual masturbation, reading erotic stories, sexting, phone sex, any activity that doesn't involve any close contact. So the 3 letters, 1 digit, and 1 symbol that has revolutionized the concept of the modern sciences. Here I'd like to reframe. E stand for erection, M stand for mask, one C for care, and another C for compassion. Thank you, respected chairperson, for giving me this opportunity. Over to you, sir.
I request Dr. Jumani sir to please introduce Dr. Rahul Reddy and Dr. Gajanan Bhatt.
Thank you, Dr. Karthikeyan and Dr. Ranjan, for that beautiful talk. Now, may I invite Dr. Rahul Reddy, who is a consultant microsurgical andrologist at the Andrology Androcare Institute in Hyderabad. He is an amazing surgeon. May I also introduce Dr. Gajanan Bhatt, who is a consultant urologist in sexual medicine at TSS in Sirsi, Karnataka. He's also a member of the Developing Countries Committee of ISSM. May I ask both of them to start their case discussions? We're running short of time. We need to be very brisk.
Rahul, you can go ahead.
Good evening, everyone. Since we are running short of time, we'll start case scenarios. Our panelists are Dr. Shivam Priyadasi and Dr. Deepak Jumani, sir. We have 3 case scenarios. First case scenario is young, 24 years, unmarried male with erectile dysfunction. He says he has lost his early morning erections. He says occasional grade 3 early morning erections, and he gives history of multiple failures in intercourse with his partner. So the investigations which are done are testosterone, total testosterone was 3.8, and all other hormonal workup was normal. And penile Doppler was done by a local urologist, which is also normal. So now how to proceed?
Sir, Jumani sir.
Yeah, this is a very simple case. It looks like a psychogenic or situational issue. Ethically, I don't need to give him any medications for erection, ethically. But as Dr. Rupin said, we need to give them something to, boost his morale, like, low dose of tadalafil or 10-50 mg of sildenafil. But what I would do is, since I know now I have a new molecule, avanafil, which has got less side effects and the onset of action is pretty fast, So I would like to give him half a tablet of avanafil, which is 50 mg if it is there. And it would be very good for him because I'm not going to give him any side effects, if at all I have to give. But what I would do is I would do a lot of counseling on him, and I would explain to him that this is normal, it can happen sometimes. So that would be my take on this case. It is purely a psychogenic or a situational erectile dysfunctions, may not need PD5 inhibitors, because if you give PD5 inhibitors as early on, you internalize a feeling in them that they will need some medicines to get erections or to sustain their erections, which is a very wrong thing to do. So I would give them a maybe a low dose of tadalafil or a half a tablet of avanafil, which is now available to me and which is very safe.
Thank you, sir. Shivam sir.
Yes. So,
Would you like to comment about the role of nutraceuticals?
Before commenting on nutraceuticals, I think very important before arriving at the diagnosis of pure psychogenic case, we need to take a very proper history and physical examination and etc. Because many of these patients may be have some different kind of thing, like they may have some drug history. Many of these youngsters may be taking certain opioids or on some anabolic steroids, etc. So we need to arrive at the diagnosis after a proper history and physical examination, and then only we should proceed. So in this case, probably if the patient has some psychological problem or issues like stress related issues, then we definitely a psychosocial counseling along with maybe PD5 inhibitor to boost up his confidence would be the best thing to do after doing maybe a off-sildenafil test. Yes, about the nutraceuticals, I think I would not prefer adding any nutraceutical in this, except L-arginine sometimes I would add. Because the rest of the nutraceuticals, probably one of the studies have even shown that 50% of these nutraceuticals contains some constituent of PD5 inhibitors. So I would not prefer any other nutraceutical, though some vitamins. We have done in our department some studies on folic acid deficiency and vitamin D3 deficiency in these patients with erectile dysfunction. So they have helped only in those patients who are deficient of vitamin D3 or folic acid. So these may be added if the patients are deficient. Yes, Gajan.
Thank you, sir. Ajayan sir, would you like to comment your opinion about nutraceuticals? Ajayan sir?
Yeah, that means normally in such cases, I prefer nutraceuticals because so patient needs placebo effect, that much only. Actually, nutraceuticals will do nothing. I know that, even though nutraceuticals works. And this thing also, cholecalciferol also, I do give. I do prescribe.
Thank you, sir. Shivam sir, one more thing. This Avanafil, do you think it's a mere addition or a game changer?
I would not call it a game changer, but definitely in a specific subset of patients, it may be helpful than other PD5 inhibitors. Like a patient, like in this patient who is an unmarried young male, and if he wants to do an unplanned sex where he wants to have a rapid onset of erection, in that case, probably it would be very helpful that within 15 minutes he will have a good erection. So in such cases, a specific subset, it may be helpful. And patients who are not tolerating maybe the other PD5 inhibitors, it may be helpful. So I don't think it would be a game changer, but definitely it may, it is another good addition to our armamentarium.
Thank you. Thank you, sir. Thank you, sir. Rahul, next case.
So we have a 38-year-old male patient with erectile dysfunction for 3 years. He is diabetic, hypertensive, and he says there are no early morning erections at all. And he tried multiple testosterone injections from a local physician that proves that it's not a testosterone deficiency, because if if it is testosterone deficiency, at least he should have some improvement. He didn't find any improvement with testosterone injections.
Sir, Ajayan sir, the question is to you, whether the presence of these comorbidities whether it alters your choice of PDE5 in this particular case, as well as testosterone that is mentioned. Ajayan sir.
First of all, we have to check which drug is he is taking for hypertension. If it is ethanol or beta blockers, then we have to change it. then after is diabetic control, whether it is controlled properly or he is taking medicine or not. Such things we have to check. Then after PDE5 inhibitor is the drug of choice for such condition, if all other things are favorable.
Whether the duration of ED, do you think it changes whether PDE5 inhibitor, something like that, or would you like to go to higher level of treatment, or your choice remains the same? PDE5.
I didn't get you.
Sir, duration of ED. Can you hear me, sir?
Yeah.
Yeah. Does it, whether it acts as a determining factor for choosing a particular PDE5, or you go along with you start with one PDE5 inhibitor. If it doesn't act, then you change over, or you add up.
Duration, it's an issue.
Duration is an issue. Thank you, sir. Deepak, sir.
Yeah.
Sir, this metabolism of this Avanext, sir. So it is metabolized by this cytochrome P450, and with these cardiovascular conditions, whether it is diabetes, whether it is hypertension, these metabolic conditions, or along with IHD, whether Avanext should be considered as a drug of choice, or whether it, while prescribing it, would you like to suggest something here?
Yeah.
Practically.
My opinion, from the early, that means from the Narasimha Rao age, that our globalization took place. But we, as far as the pharmaceutical industry is considered, such drugs are not available. Thanks to Sidus Canilla, at least they brought this molecule in India. Then such molecules are helpful, and we can prescribe that.
Thank you, sir. Jumani, sir, your opinion?
Yeah, as Avanext we know is metabolized in the liver by cytochrome P450 GP34 enzyme, and 62% of it is excreted in the feces and 21% in the urine. There have been the studies which we have gone through don't say that you need to change the dose of Avanext. But yes, Avanext would be a very, very good choice in these patients who are having metabolic syndrome. But all said and done, the metabolic syndrome has to be corrected. His diabetes has to be corrected. His hypertension has to be corrected for sure. And we can try PDE5 inhibitors in the form of Avanext to the dose of 200 milligrams and try, and he may improve.
Thank you, sir. Thank you, sir. Rahul?
Sir, Shivam, sir.
Yes.
So what is the role of L-arginine? Do you prefer L-arginine in these patients? If yes, how many days?
L-arginine,
along with PDE5s.
Yes, I do give L-arginine in many of these patients, so it is usually for maybe about 3 to 6 months if it is a long duration persistent erectile dysfunction. So at least 3 to 6 months. But though other nutraceuticals I usually do not.
And dosage, sir? 2,500 or 5,000 milligrams?
It's usually 3 to 5 grams, yes. But
along with PDE5 inhibitor or only LH?
Along with PDE5. I do not give it alone.
So third case scenario, sir, we have 57-year-old male with erectile dysfunction since 5 to 6 years. Again, he's a diabetic, hypertensive, smoker, and on visual scale, it's only grade 1 erection. And he's not able to perform intercourse since last 5 to 6 years. So, your opinion, sir? It's a clear-cut case of most probably it should be arteriogenic ED since he's getting grade 1 erection.
Sir, Shivam sir.
Yes.
Sir, it's a direct question. What is the chance that a PDE5 acts in such cases?
These PDE5 inhibitors may act in some of these patients. Maybe I think in 1/3 of these patients, PDE5 inhibitors may act, but they may not continue to act in some of these patients, and even many of these patients may not respond to PDE5 inhibitors. So we need to see also if these patients are quite old, maybe we need to see the hormonal profile also in these patients, the diabetic profile, if there's hypertensive and on other medications also. So after all these things, we definitely will give him a trial of PDE5 inhibitor. And if he is not responding to PDE5 inhibitor, then we will try to have a patient put on a home self-injection program if he is responding to bimix or trimix injection. Or sometimes even a vacuum erection device. So if the patient is not is quite satisfied with vacuum erection device, he may be put on even a vacuum erection device.
Thank you, sir. Deepak, sir.
Even after controlling his complete metabolic syndrome, and since he's having a long-standing erectile dysfunction, he's tried all PDE5 inhibitors. Avanafil is a new molecule which he can try. If it works, it's well. Otherwise, this case is a pure case for penile implants. I would not give him anything else. I would straight away send him to Dr. Rupin or Dr. Vasan or Dr. Reddy for the further management if he wants a good quality of life.
Ajayan, sir, do you agree with him?
I differ.
I knew.
Normally, I prescribe tadalafil 20 mg daily or alternate days, and avanafil I do not know. So far, I didn't prescribe, and sildenafil 100 mg before sexual intercourse, 1 hour before sexual intercourse. 30% of such cases will recover if the comorbidities are controlled, and as well as smoking is. That means he should stop the smoking also. Then the drugs, as I told in the previous case, what if he is taking beta blockers, it should be changed, and diabetic control must be there, and physical exercise, such things should be there. Then that means lifestyle changes. If it is not working, then I will go for bimix or trimix, at least 2 or 4 units, and I could have so many patients in similar cases. My drug of choice is 20 mg of tadalafil daily or alternate days, and SOS sildenafil 100 mg. If it fails, I have no experience with avanafil, that's why I am not mentioning that. It may be helpful. That means 200 mg. If it is helpful, then 200 mg must be prescribed. Then after, the intracaverous injection, that means 2 units or 4 units. Even if it is not recovering, we can improve, increase the dose also. That is my mode of operandi.
Thank you, sir. Thank you. Rahul.
Sir, I think we have to close. We are running short of time.
We thank all the panelists, Ajayan sir, Shivam sir, and Deepak sir. Thank you. And we thank Vasan sir and Rupin sir for giving this opportunity. Thank you very much, sir. So handing over to Vinod sir for expert comments. Thank you, sir.
Thank you, sir.
Dear friends and senior teachers, we had a very elaborate session on erectile dysfunction management. Even though it is more focused on avanafil, we have discussed so many things about management of erectile dysfunction. We were going through sildenafil, tadalafil, vardenafil, avanafil, udanafil, and merodanafil, and some of them which is not mentioned about laudanafil, which is also a player. Of this, we have sildenafil, tadalafil, and vardenafil are FDA approved, and udanafil is pending an FDA approval. They have given the application; it is not approved so far. And merodanafil and is available only in Korea, and laudanafil only in Brazil. So now we are getting this avanafil in India after it has been introduced in US in the name of Stendra, and it is available in the European Union as Pedra, and in other parts of the world also it is available. We are happy to get a new molecule introduced to our country because we have a new armamentarium. So our question will be today as a take-home message: in this present scenario with too many PDE5 inhibitors, is there any need for another PDE5 inhibitor to us? That is a question we have to carry home. The answer of this question we have to carry home. Even though we have many PDE5 inhibitors, we have discussed only 60 to 70% of them are finding a response. So that means 30 to 40% of the responders are not happy even if they have an erectile dysfunction. Even though we have a 30 to 40 non-responsive patients and 60 to 70 is responding, of the responding patients, around 30 to 40 are not happy. And in 2 to 3 years, more than half of them drops out. This is the experience we get from the field when you do a field study or a surveillance study. And some of the reasons will be the side effect profile. So this data points to the need for further drugs and further improvements. We need something to be improved upon. And we know that all drugs are introduced with a promise. Sildenafil, it was a breakthrough because we had no other drug. Tadalafil, once it is introduced, it was mentioned as a weekender pill. You take it in a weekend and forget about it, and you have a nice sexual life for 48 hours. This brought back the spontaneity of sex, which helped to have the unplanned sex. So that was its hallmark. So what do Avanafil provide you as a unique feature? So I am taking a little bit points from different speakers and making a summary. The main point is it has a quick onset of action. As it has to be taken only 30 minutes before sex. That anybody can take. This is better than sildenafil anyway, because the time duration is very low. But may not be up to tadalafil. But the question to the patient will be, why should you carry a drug in your body if you don't want that after the sex? So if you want to have sex, you take Avanafil, have sex. So that is an advantage over tadalafil. For Avanafil is having that much advantage over tadalafil. Now coming to the adverse reactions. This drug has high selectivity for PD5 than PD1, which is in the heart, PD6, which is in the eyes, or PD11 in the skeletal muscles. So it doesn't have that the blurring of vision which sildenafil may produce, or the low back pain which tadalafil may produce. If you look at the side effect profile, it may look almost similar, but the bothersome problems are very less. And in that way, Avanafil is an attractive option to us. Now, literature shows that all of the available drugs, there is no superiority in efficacy proved for any particular drug. So do we need one more drug? At the same time, we know that sildenafil non-responders have improvement when PD5 inhibitor is switched, as Dr. Karthikeyan has mentioned. So how this two can be true? So this proves the necessity of another PD5, especially a second generation one like Avanafil. So if you want to switch off to another drug, why don't you switch off to a better drug like Avanafil, which is a second generation drug? But what is the explanation for this? because there is no superior efficacy for any of the drug. So this may be explained in the light of pharmacogenetics only. Dr. Karthikeyan has just mentioned about that in a brief description. I will explain it. Consider we have a study group of 30 patients and we are grouping them into A, B, C. Consider sildenafil is effective against A and B. So 2/3 patients are having some effect. 66% is its efficiency. Let us assume that avanafil is acting on B and C, not in A. So it also has the same efficacy. But we know that the C will get effect only if avanafil is used. So this is an analogy. Is it applicable in our body? Yes. How? PDF5 has 3 isoforms: PD5A1, PD5A2, and A3. Similarly, we have many other genotypes associated with the nitric oxide signaling pathway. They show polymorphism. We may not be able to subset those patients. It is just like your blood group. You'll be having PD5A1, your friend will be having PD5A2. So we may not be able to make it a subset. If you need that, you need to go into the pharmacogenetics, which is very expensive. So once the pharmacogenetics is advancing, we will be getting a clearer answer why this is active in such patients. So there is always a need for multiple drugs in your armamentarium when you're treating erectile dysfunction. So the role of avanafil is there. Now, when you take the prescription pattern of the study of prescription pattern, you find that when patients are given options of different drugs, their compliance is increased. More than 80% of them get compliant if you're providing them different options, because different people will like different drugs. So it is very happy that we are getting one more drug to our armamentarium to treat our patients and can help our patients and have a good and active sexual life. Thank you.
So thank you so much, Dr. Vinod sir, for your precise and clear take-home message from today's event. With that, I think we come to the end of this event. So as everyone rightly said, whenever the new drug comes to a market, there are a lot of ifs and buts and a lot of concerns which are always roaming in our mind. And even the Avanext is not exceptional to that. But last 2 hours and so is an absolute treat to our viewers. I must say it is an absolute masterclass by our fantastic faculty. I'm sure many of their doubts have been resolved and they have enjoyed this Saturday night treat. So I would like to thank our chairperson, Dr. Rupin Shah, Dr. Narayan Reddy, Dr. Deepak Jumani sir, Dr. Ajay Vagase, Dr. Shyam Pradarshini for their valuable time, their active participation and the guidance throughout the session. I would like to thank our speakers, Dr. Vinit Manotra, Dr. Pramod Krishnappa, Dr. Raman Tanwar, Dr. Karthikeyan, Dr. Ranjan Bhattacharya for enlightening us about the various PD5 inhibitors and specifically about the Avanext. I would like to thank all our moderators, Dr. Vasan, Dr. Vinod, Dr. Rahul Reddy, and Dr. Gajan Bhatt for driving the session so well. Without the help of you guys, the launch has not been possible. And lastly, I would like to thank the team of Zydus from head office to the field to making this event possible. Because of the time constraint, if we are not able to answer all the questions, so we will reach out to all our viewers through their registered email. So yes, we thank you again, and our team will reach out to you, all of you, with other samples very soon, and we need your supports to make it a big. So thank you so much. Till then, please be safe, keep smiling, and we are signing off. Thank you, everybody.
Thank you, Sachin. Thank you, everyone.